Good morning, everyone, and thank you for joining us. I'm Cheryl DeMars. I'm the President and CEO of the Alliance, and it's my pleasure to welcome you today to our webinar focused on health policy topics. We have a potpourri of topics to talk about today, everything from the potential impact of the presidential election to COBRA, transparency, surprise billing, a range of issues that are important to employers and certainly Alliance members. We have about 158 people registered for this event, which is awesome. You're all in mute mode, but we want to hear from you. So please, if questions come up during the webinar, use the chat feature that you'll see on your screen to note your question, and we'll feed those in at the end of the session during the Q&A. We've got a lot to cover, so we're just going to get right to it. It is my pleasure to welcome Elise Schuman and Katie Johnson from the American Benefits Council. And before I introduce each of them, I just want to take a moment to talk about the good work of the American Benefits Council and their importance to us as a partner. We have been a member of the American Benefits Council for a while, and you may, as a member of the Alliance, see information that we pass along to you about educational webinars that they make available. This is a special privilege that Alliance members enjoy by virtue of our membership with the Council, our partnership with them. Over the summer, you may have participated in the three-part series that took place on how to bring employees back to work in the midst of COVID. We also want to thank the American Benefits Council for the amazing leadership that you all took to put together a national multi-stakeholder coalition that effectively repealed the Cadillac tax through their efforts to fight the 40. It was really amazing, and we were so proud to be part of that. So now let me introduce our speakers. Elise Schuman is the Senior Vice President of Health Policy for the American Benefits Council, and in this role, she directs the development and advocacy of the Council's health policy priorities. Before joining the Council staff, Elise was the Council Board of Directors Advisory Council representative from the law firm Littler Mendelson PC, where she was co-chair of the Workplace Policy Institute. And in this role, Elise provided strategic counsel and representation to clients on a broad array of workplace issues and developments in Congress and the executive branch federal agencies. She was also a member of the firm's ERISA employee benefits practice and co-led the firm's legislative and regulatory practice. She holds a bachelor's degree from Tufts University, Jackson College, and a law degree from Georgetown University. Katie Johnson is Senior Counsel of Health Policy at American Benefits Council, and Katie assists Council members on a wide range of health policy issues and directs the Council's activities with respect to healthcare reform, ERISA, and other federal regulations impacting employer-sponsored health benefits. Prior to joining the Council, Katie was an attorney advisor in the Office of Benefits Counsel, Tax Counsel at the U.S. Department of Treasury. And before that, she served as an attorney in the Health and Welfare Branch of the Office of Chief Counsel at the Internal Revenue Service. Katie is a Phi Beta Kappa graduate of Middlebury College and graduated from Stanford Law School, where she served on the managing board of the Stanford Law Review. Katie, Elise, welcome, and thank you so much for joining us today.
Okay. And Cheryl, thank you so much. And let me just say how much we value the special relationship that we have with the Alliance. And thank you so much for mentioning our joint and collective successful efforts in repealing the Cadillac tax. And I think that is such a prime testament of how important it is for employers' voice to be heard, and that it does indeed make a difference. So if we can get our slides up. And, you know, we didn't know if we would have to make any last-minute changes to the presentation today. And with the election now just 26 days away, things have been changing by the hour and perhaps even as we speak. And as the pandemic and politics converge amidst a public health and economic crisis, the stakes could not be higher for Congress to pass additional COVID-19 relief and economic stimulus legislation. But the prospects for passing broad bipartisan legislation before the election are on life support and don't seem very likely before the election. On May 15th, which already seems like a lifetime ago, House Democrats passed a more than $3 trillion package. 4 months later, Senate Republicans responded with their own narrower bill, what fell short of the 60 votes needed to advance. In the wake of Justice Ruth Bader Ginsburg's death, Senate Republicans are now focused on expediting Amy Coney Barrett's nomination through the chamber, possibly before the election, although the COVID diagnosis of several GOP senators may complicate that. Her nomination leaves the future of the Affordable Care Act in doubt with the pending lawsuit that's before the Supreme Court challenging the law's constitutionality. How this factors into the election and afterwards remains to be seen. Meanwhile, last week, House Democrats passed a scaled-down version of their earlier COVID stimulus bill. Speaker Pelosi and Treasury Secretary Mnuchin nonetheless continued their dialogue to try to find common ground, although the sides seem far apart. Earlier this week, President Trump seemed to scrap ongoing talks on the stimulus, but then again, maybe not. So where does that leave things? Pretty much nowhere before the election with regard to broad COVID relief and stimulus legislation that could also include health policy provisions. There does, however, seem to be some discussion around a possible narrower airline relief bill. But when Congress passed legislation funding the government through December 11th, they effectively punted any stimulus bill, if there is one, and if it includes policy provisions, until after the election. While the lame duck session of Congress proves to be, whether the lame duck session of Congress proves to be fruitful very much depends on the outcome of the election. If there is a new administration, particularly if Democrats gain control of the Senate, they may want to wait until the new year and the new Congress to act. So the bottom line is we can't really count on the lame duck session for anything other than government funding. However, events or pressure to key congressional champions and stakeholders may change that, which is why, again, it's so important for employers to have their voice heard. And, you know, this next slide is really interesting because I think the message of how legislation has changed is so important because it really explains where we are in terms of the impact of an increasingly polarized Congress on the legislative process. And it may foretell of what we can expect in the years ahead when moderates used to hold the deciding votes and their support was critical. Significant healthcare legislation was indeed bipartisan. Think Medicare or ERISA or COBRA or HIPAA. Now, however, moderates in both parties are nearly extinct and virtually irrelevant, and major legislation has evolved into a largely partisan exercise. Major pieces of legislation, the Affordable Care Act, the effort to repeal the Affordable Care Act, the tax reform bill, the Tax Cut and Jobs Act, were all partisan efforts using or seeking to use the Senate budget reconciliation process to avoid a filibuster and the need for bipartisan support. If there's a Democratic sweep of the White House and Congress, this may well be the process used to advance sweeping healthcare legislation. You know, there's a lot of talk about polls now. And, you know, if you're like me, I am checking numerous times a day the website Real Clear Politics for the latest polls. And I look at their average, their Real Clear Politics national average, which of about 30 minutes ago shows Biden with a 9.5 lead. but we don't really have a national election. The election is really fought in key battleground states, and where in 2016, Trump was propelled to victory by just over 79,000 votes in these battleground states. I note that the Real Clear Politics battleground state average has former Vice President Biden up by 4.6 points in those battleground states. But in politics, 26 days is still an eternity. And we wonder how many more October surprises there could be. But let's also, it's not just the White House that's at stake, it's Congress too. And control of Congress is still in the balance. Democrats are widely expected to maintain control of the House, maybe even increase their margins. In the Senate, in which Republicans currently control with 53 seats, the battle looks a bit more uncertain. But Republicans were already at a disadvantage, having to defend 23 seats versus 12 for the Democrats. And the fate of Senate Republicans may well be tied to that of President Trump. And health policy during the pandemic and after is in the balance. Cheryl mentioned COBRA subsidies. So let me dig into some of the specifics about what we could expect in terms of health policy for the remainder of this year. With negotiations on another COVID stimulus bill at a standstill, hopes for Congress passing legislation to shore up employer-sponsored health care and other health policy priorities before the election looks unlikely. The slimmed-down Senate Republican bill that failed to advance did not include the health care priorities we'd been advocating for, including COBRA subsidies or significant financial support for COVID testing or surprise billing or telehealth. The original House-passed HEROES Act, the version that was passed in May, would have provided 100% subsidy of premiums for terminated workers who were enrolled in COBRA, as well as assistance for furloughed workers remaining on their employer plans. Yet the COBRA subsidies was not included. It was stripped from the House, the narrowed House Democrat bill that passed the House last week. In its place was a proposal that would make all workers who were getting unemployment insurance automatically eligible for premium subsidies on the ACA exchanges. And I think this could be seen as a lack, and a troubling lack, of broad support for employer-sponsored insurance, and also reflective of ongoing concerns about the cost of COBRA subsidies and disputes about the application of abortion restrictions to those subsidies. With the prospects for action before the election dim, then we're going to turn our sights realistically to the lame duck session. And as I noted before, funding for the government was extended to December 11th, So there could be another bite at the apple during the lame duck session of Congress. That being said, I think COBRA subsidy legislation still does face significant headwinds, in addition to the fact that negotiations over a broader package remained deadlocked. Questions about cost and some Republicans in the administration questioning the need for COBRA subsidies. And compounding the challenge is an ongoing dispute about the application of the Hyde Amendment abortion funding restrictions to COBRA. Meanwhile, the employer-sponsored healthcare system has been under intense scrutiny during the COVID-19 pandemic, facing renewed calls from progressives for Medicare for All, and also some criticism from conservatives as well. The Council and Alliance to Fight for Healthcare, that's our rebranded Alliance to Fight the 40 coalition, continues to push for COBRA subsidy and also consider other policies to shore up employer-sponsored coverage during this public health and economic crisis. Our message to the lawmakers before the election, and I think after will be, is that voters overwhelmingly want Congress to act, and they want Congress to act now. And it's going to be critical, again, that we continue to deliver that message and let the voice of employers be heard. Another issue that has gotten a lot of attention but no firm action thus far is the issue of surprise billing. A broader surprise billing fix was not included in either the House Democrats legislation or the Democrats Republican bill. The council has advocated for over a year on a legislative solution to the problem of surprise billing from out-of-network providers by prohibiting balance billing and using a local median in-network rate as the reimbursement benchmark, and is pushing for inclusion of this in a COVID relief package. Without a COVID bill, likely, surprise billing, however, doesn't have a train to ride on. So I think that's the challenge right now. And also, there's still some disagreements among the committees of jurisdiction in Congress about what approach to take. And the Ways and Means Committee is really advocating for a more provider-friendly arbitration approach. Although the Senate seems to have resolved its differences and worked with Senator Cassidy, a doctor, and other members on a compromise. But I would think that any further directions than to get the House Ways and Means Committee and the House on board may involve further concessions in that direction. However, surprise billing remains a top priority for the retiring chairman of the Senate Health Committee, Lamar Alexander. And surprise billing is really part of this broader effort to address rising healthcare costs. It was part of a broader legislative effort by the Senate Health Committee and Senator Alexander to lower healthcare costs. And that legislation, the Lower Healthcare Costs Act, which surprise billing was part of, also included a number of other important provisions designed to help employers lower costs and improve the quality of healthcare by, for example, enhancing transparency and competition. And I do want to remind you all that the Alliance was invited to testify before the Senate Health Committee on what employers are doing to control costs. And this testimony, along with that of many others, was used to develop the Lower Healthcare Costs Act. And we're really pushing to get that over the finish line this Congress. And again, a testament to the fact that your voice really does matter and make a difference. I do just want to mention that there was a recent executive order by the White House to try to push Congress to come up with a surprise billing legislative fix by the end of this year. And if not, they would take the action. They didn't specify what action they would take. And I think that executive order has been described by some as kind of a big nothing burger. But it does really leave the surprise billing legislation firmly in the hands of Congress. It's going to be a challenge, nonetheless, I think, to get something across the finish line this year that truly does fix the problem. But with Senator Alexander no longer at the helm of the Senate Health Committee next year, it's unclear what direction surprise billing could take next Congress if it's not acted upon this year. Now turning our sights to something that is I'm sure, top of mind for so many of us as we try to get our way through this pandemic, and that is COVID testing, the importance of COVID testing, and also looking ahead to a vaccine. And while we're all pinning our hopes on a vaccine to end this crisis, but even if it's safe and effective and a vaccine is developed by the end of the year, it'll take some time for the vaccine to be widely administered. So the reality is that employers will need to be planning for workplace strategies to contend with COVID-19 likely through 2021, and testing may be a key component of that strategy. With employers effectively stepping into a public health role and the prospect of wide-scale testing for the active virus and or antibodies, the question of funding to support COVID-19 testing for public health surveillance and occupational health purposes, as well as diagnostic purposes, has taken on greater significance. As a reminder, the regulators have issued guidance on a Families First Act mandate. That's earlier legislation, COVID relief legislation that Congress passed. And there's a mandate in that legislation that group health plans cover COVID-19 without cost sharing or medical management. And the regulatory guidance in the form of frequently asked questions clarified that that would not apply to employee return to work or public health surveillance purposes. We have urged Congress to support the efforts of employers to return their employees to the workplace safely by investing additional federal resources in robust testing needed to accomplish both the nation's public health and economic goals. But without a COVID relief bill on the horizon, there's not been a vehicle to accomplish this goal with robust government support. I also want to note that I expect questions around the costs of vaccines. Group health plans are mandated to cover COVID-19 vaccines immediately and without cost sharing. And this issue could become more prominent as we hopefully get closer to having a safe and effective vaccine available and administered. As with testing, questions around the respective roles and responsibilities of employers, group health plans, and government in meeting the nation's goal will likely intensify. I want to spend a few minutes talking about telehealth because certainly the COVID-19 pandemic has really fueled efforts to expand access to telehealth services. A recent report by McKinsey estimates that up to $250 billion or 20% of the current U.S. healthcare spend could potentially be virtualized. The Council has urged Congress and the regulatory agencies to take action to increase the ability of employers to offer telehealth services, including looking beyond the pandemic and making permanent a provision in earlier COVID relief law that allows HSA-eligible high-deductible health plans to cover telehealth without cost sharing. We've also called for removing state barriers to offering telehealth services and also allowing employers to offer more robust telehealth services to non-benefits eligible employees. The regulatory agencies issued some helpful guidance on that front, but we're supporting legislation to build on that guidance. And I do also want to point out that there are some legislative efforts that could actually potentially undermine value-based care and efforts to drive lower cost and higher quality health care by imposing some requirements that in-person telehealth services be paid the same rate as virtual telehealth services. So, again, that's an apples and oranges comparison, and I think we want to be very cautious and concerned and are trying to push back on any efforts to expand telehealth services that would have the effect of actually undermining those broader efforts. But even if no additional telehealth legislation passes this Congress, I certainly expect that telehealth will continue to be a focus in the next. And with that, Katie, I think I'll turn it over to you.
Thank you, Eileen, and hello, everyone. Thanks so much for having Eileen and I today. So as Eileen mentioned, we are going to talk now, as we have been, about some items that we expect to see through perhaps the end of this year. I'm going to focus on the regulatory side of things on the health policy front before we pivot to what we might expect in a forthcoming either Biden or Trump administration. So one thing I wanted to make sure that we cover are the administration's efforts with regard to price transparency. Going back in our time machine to June of 2019, the President issued an executive order on a number of issues, including price transparency. And a lot of different regulations have come out of that executive order, including with regard to hospital price transparency, which you may have read about. What I wanted to focus on are the requirements that flowed from that executive order and also from an Affordable Care Act provision that imposed price transparency requirements on group health plans and health insurance issuers. So there's a provision in the Affordable Care Act that imposed certain requirements that was not actually implemented by the Obama administration. As Cheryl mentioned, I worked in the Treasury and IRS groups in implementing the Affordable Care Act back in the day, and there were so many Affordable Care Act provisions to implement. We had to make basically a 6-year plan to take a bunch on at a time and then move on to the next batch. So the price transparency rules were not implemented by the Obama administration, but are being implemented by the Trump administration. And so late last year, we saw proposed rules on these requirements for group health plans and health insurance issuers. There are two main elements to the requirements. One is that plans and issuers would be required to provide an internet-based self-service tool that would provide pre-service cost-sharing estimates for individuals, and those would be individual-specific. So if Eileen had met her deductible and I hadn't, and we were looking up the same service with the same doctor, our estimates would be different. So they need to be specific to the person and capture where they are in their cost sharing. And also need to be based on the actual negotiated rates for the provider that's being looked up in the tool and for the service. As proposed, the requirement would cover all items and services covered by the plan. The second element to the requirement is that plans and issuers would have to make publicly available a machine-readable file of the negotiated rates for all of the in-network providers for all items and services under the plan, and then also a list of historical allowed amounts for all items and services covered under the plan as well. These proposed rules garnered a lot of attention, both positive and negative. Of course, major efforts to increase price transparency for plans and issuers could be extremely valuable, as Elise was mentioning, as part of efforts to reduce healthcare costs. And so a number of folks, including the council, are very supportive of efforts to increase price transparency as a means to reduce healthcare costs. At the same time, there are a number of aspects of the proposed rules that could be difficult to administer or potentially burdensome or raise other issues. So I mention all this to say that over 25,000 comments were filed, which is noteworthy in and of itself. That's a really high number of comments. What's even more noteworthy is that those comments, generally speaking, are really robust and really meaty. Our comment was over 35 pages. You know, that is not typical, and a lot of other folks' comments were really robust. So this is to say the agencies have a heavy lift here in going from proposed to final, because they're required to take into account all of those comments and address them, decide whether they're going to make changes or not, and consider the points raised. We've been curious, because of the heaviness of the lift with this regulatory priority, whether it would have been significantly derailed by the need of Treasury, Department of Labor, and Health and Human Services to pivot and focus their efforts obviously on addressing the pandemic. But interestingly, you know, I kind of checked in with agency folks over time, and they indicated that as early summer, they kind of got the full team back together and started working full-time on the price transparency rules. So it is still an administration priority to finalize these rules by the end of this year. On September 11th, we saw that the, sorry, I'm having a little echo there. On September 11th, we saw that the final rules went to the White House Office of Management and Budget, which is an indicator that lets us know that they're almost going to be publicly available. Usually it's weeks, sometimes it's months. I've tried to do some sleuthing to figure out where we are in the process on this one. Some folks tell me that there's still a bunch of substantive issues they're working through. Others indicate they're pretty close. I've heard some people saying that there are thoughts that it'd be great to release this before the election. Some people think it's better to release it after the election. So the fact that I can't get a clear read on it makes me kind of curious, but I think these rules are fairly imminent, definitely will be finalized before the end of this administration. And there are a number of really big ticket and interesting items. I can't wait to check the document to see where they land. things that are really important, like whether they've narrowed the scope at all of the requirements. And as always, the first thing I check is the effective date. As proposed, it was a 1-year effective date, but we asked for at least 2 years because these new tools can be really useful for consumers and participants, but also are going to be a fairly extensive lift to create properly. So hopeful for sufficient time to implement these in the way that they deserve to be implemented. Elise, I wasn't sure if you wanted to say anything on legislative efforts on the price transparency front. I know you already mentioned briefly the Lower Healthcare Cost Act.
Yeah, I just want to again reiterate, efforts to try to get the Lower Healthcare Costs Act across the finish line this year. It is a priority for retiring Chairman Alexander, and the goal of transparency and pushing for more value-based care and more competition. Some really critical provisions in there. The best chance those provisions have of making it across the finish line this year for there to be a surprise billing fix, and for that to happen, I think there also has to be a larger vehicle for that to ride on.
Great. The last note I wanted to make on price transparency, and we'll get into this a little bit more in a few minutes, but what I find kind of interesting is that we have the administration prioritizing price transparency efforts, which they have done across the board. But as I mentioned, the statutory basis for these price transparency requirements is a provision of the Affordable Care Act. At the same time, just wanted to note so we can keep it all in mind, the administration is also supporting, as part of a current Supreme Court case on the Affordable Care Act, an overturning of the Affordable Care Act. And if the entire Affordable Care Act were to be struck down, the statutory basis for the price transparency requirements would be struck down. So I just want to note that that looming Supreme Court case probably has some kind of tentacle in everything Elise and I are talking about today, but this one I think is particularly stark. As we'll talk about in a little bit, it's not entirely clear to me, at least, that if the Affordable Care Act were to be struck down, the whole thing would be gone, and it may just be parts and pieces, and it'll be interesting to think about where price transparency falls. But that's something else to keep in the back of our minds. One is we're waiting to see the final regulations, but we're also waiting to see the outcome of the related Supreme Court case. Now I wanted to touch on what I think is another big ticket potential regulatory item that we may see soonish, but not entirely clear when we might see this, but wellness plan regulatory activity. So I'm sure, as we've all had to deal with, wellness plans can be really valuable and important and helpful. Also, with my lawyer hat on, they can be tough because they are subject to so many different statutes that you have to always be keeping track of. So wellness plans are subject to HIPAA, of course, and there were some statutory changes in the Affordable Care Act, and so we've had final rules under HIPAA since 2013 that are clear on what kind of incentive limits employers can offer in wellness plans and still be compliant with the HIPAA health non-discrimination rules. So that's set. What's been less settled is the application of other laws to wellness plan incentives and when they are and aren't permissible. In particular, under the Americans with Disabilities Act and to a lesser extent, but relatedly, the Genetic Information Non-Discrimination Act. What's happened is in 2016, the EEOC, the Equal Employment Opportunity Commission, issued final rules which explained when it will be the case that a incentive limit provided under employer-provided wellness plan would be considered to be compliant with the Americans with Disabilities Act. The concern there is that if the wellness plan offers an incentive that is so large that it renders participation in that wellness plan involuntary, you can have a problem under the ADA. So the EEOC and the Obama administration put out rules saying, basically, we're trying to align the EEOC ADA rules with the HIPAA rules such that, didn't perfectly align, but basically in spirit, you offer a no more than 30% of an incentive, 30% of the cost of the health care of an incentive for a wellness plan. That will be okay under the ADA for health contingent wellness programs. That's the wellness programs where the ability to gain a reward is based on satisfaction of a health-related factor. And then for participatory wellness programs where you just have to participate in the program and the satisfaction and achievement of the reward is not related to a health factor, there was no limit under the HIPAA rules. What happened next, though, was that the AARP sued the EEOC, a lot of acronyms here, on the final Americans with Disabilities Act wellness rules, and saying that those rules did not comply with the Americans with Disabilities Act, and that EEOC had failed to go through the proper processes to finalize those rules and hadn't sufficiently justified their position. And so EEOC ultimately withdrew part of the rules that said what kind of incentive limits are permissible for a wellness plan under the Americans with Disabilities Act. So we've been left since the beginning of 2019 with that part of the regulation missing. So we've been watching and waiting to see if EEOC was going to repropose new incentive limits under the ADA for wellness plans. And what was interesting was in June, kind of at least from my perspective, out of the blue, EEOC announced that they were going to hold a virtual hearing, a teleconference that Ilyse and I listened in on, and they were going to be voting on new proposed wellness regulations. And so in that meeting, they verbally described these new proposed wellness regulations under the ADA, which generally speaking, again, this is based on the verbal discussion in this meeting. We haven't seen anything in writing, that the rules would basically, for health contingent wellness programs offered in connection with a health plan, as long as those were compliant with HIPAA, they would be fine. They're basically going to be falling under what's called an insurance safe harbor, so meaning that compliance with HIPAA would be sufficient. But as we understood from that discussion in June, for participatory wellness plans and for wellness plans not offered in connection with a health plan, those would have a de minimis incentive limit, and they didn't discuss what de minimis would mean, which, as we all know, is going to be really the crux of things if it turns that permissibility is what determines the viability under the ADA. So the next step after that hearing was for EEOC to transmit those proposed draft rules, which were voted on, I should mention, in that EEOC hearing 2-1. So they were approved by 2 of the commissioners, which was sufficient for them to be adopted basically and approved. They were supposed to go then to the White House Office of Management and Budget to be reviewed by all the different agencies who might have some kind of equities and want to review it. We haven't formally seen it submitted to OMB. That's publicly available on a website for OMB. You can see when regulations go to OMB, and you can see when regulations leave OMB, and it's an interesting thing to track. So our understanding by inference is that they must still be being worked on. And so we would expect sometime to see proposed rules. I mean, it's relevant that they had a draft that was voted on 2-1 and approved, so that's more progress than I had been aware of. But where things stand right now is not entirely clear. I wanted to mention one other context item just to help us all kind of try to tell the future here, which is that also in the last few weeks, what's interesting is that we have had 2 new EEOC commissioners appointed. So 2 of them have been confirmed, and then one of them was actually fully confirmed by the president. One still hasn't been officially added to the commission yet. So that is to say, over this few weeks here, we're going to have 2 new EEOC commissioners. As we all know, oftentimes when you have new folks in place who are at the tippy top of an organization and you have a big undertaking, you need to make sure that person is up to speed and brief them sufficiently and loop them in. So that could serve to slow things down, but it's unclear. So we're watching to see how the new commissioners settle in, and of course watching to see what happens with this regulatory initiative, because it's really important. Okay, so now I wanted to just run down a few things here. I'm happy in the question and answer section to talk about some of this a little bit more if anybody finds it relevant to them, and some of these things may be more peripheral for you all, but I wanted to briefly mention that in the spring of 2019, the administration issued final rules which effectively allowed employers to provide tax-free money to employees to go to the individual market or the exchange. As you may recall, the Obama administration had shut that practice down around 2014. The concern had been that employers might cherry-pick sicker employees and send them to the exchange and ruin the risk profile of the exchange and lead to the feared exchange individual market death spiral. So the decision was made to prohibit employers from providing employees health reimbursement arrangements to send employees to the individual market. The Trump administration put a lot of work in to try to re-allow that practice, but to do so with a lot of parameters to try to protect the health of the individual market. So employers are now allowed, beginning in 2020, to send employees to the exchange with tax-free money and a health reimbursement arrangement, but there are a lot of bells and whistles attached with that individual coverage HRA, as we now call it. What we hadn't yet seen were the regulations that tell an employer that's a large employer when that offer of that individual coverage HRA is going to be sufficient to help that employer avoid an employer mandate penalty. So rules along those lines were proposed last fall, but we haven't seen final rules yet. So I just wanted to mention for anybody who's interested in individual coverage HRAs or defined contribution healthcare generally, that yes, we saw really robust rulemaking in the middle of 2019, but there are a couple odds and ends still coming through the pipeline, including closing the loop on the employer mandate interaction. The proposed rules can be relied upon. I've talked to my IRS sources, who I got the sense that finalizing this rule wasn't the tippy top of their priorities list, in particular because the proposed rules can be relied upon. And I also don't think a lot of large employers, at least at this point, have indicated they're offering individual coverage HRAs, but that's something we should be seeing final soon. On Affordable Care Act reporting, again, this is the reporting that employers and issuers have to do, both to show that they provided coverage, which used to be relevant for the individual mandate, and that they offered coverage, which still is relevant for the employer mandate. We oftentimes this time of year see reporting relief, which allows employers and issuers to have a little bit more time to furnish the forms to employees and give good faith relief with regard to accuracy and completeness on that reporting, because for any of us who've been involved in standing up that program, it was really quite something, and everyone did their best, but there have been a lot of hiccups along the way. So late last Friday, we did see that for 2020 reporting in 2021, IRS is going to provide the same relief they have for the last few years. Also wanted to mention that some of the reporting forms this year are being updated to take into account individual coverage HRAs. I wanted to make sure to mention direct primary care arrangements as well. I know that's something that the Alliance has been involved in and focused on, which is great to hear. The Council also has been involved in efforts to support direct primary care arrangements. In terms of why I have it listed in our other potential guidance list right here is because there was an executive order about maybe a year and a half ago directing Treasury and IRS to put out regulations saying that the payments for direct primary care arrangements are considered medical care under the Internal Revenue Code. That would allow people to deduct those amounts on their taxes and to seek reimbursement from some account-based health plans. What's interesting is that preceding that, so from the very beginning of the Trump administration has been extremely supportive of direct primary care arrangements and really pushed agency folks to come to a good solution on allowing individuals to have a direct primary care arrangement and a health savings account. That's been the focus of the problem and the crux of the issue of holding back the ability of employers to more in a broad-based way offer direct primary care arrangements to supplement the traditional coverage that they offer. The Treasury and IRS crew did not feel they could get there legally, and so what we ended up with was a more narrow proposed rule saying that expenses for these arrangements are considered medical care, but the preamble said, and in most cases, if you have a direct primary care arrangement, you're not eligible to contribute to an HSA. So we submitted comments on those proposed rules, emphasizing the importance of addressing this barrier to direct primary cares and addressing this HSA interaction piece, but acknowledge that we are working really hard on the congressional side of things to work with Congress to address that, including along the lines of legislation like the Direct Primary Care Enhancement Act. So we've emphasized kind of more generally in response to IRS and Treasury that we understand that legislation is probably needed, but we're trying to ask them to please help support the congressional efforts there. I wanted to let you guys know that one thing that was interesting was last night there was a quite long hearing of IRS on the phone where I testified on the importance of direct primary care arrangements for employers. And it was interesting to hear folks talk about DPC arrangements for so long. The administration is still taking this effort really seriously, doing what they can to support direct primary care arrangements, but from what I gleaned from comments from the IRS Treasury panel, that there are limits to their authority to address the HSA issue through regulations, and they made that pretty clear reading between the lines. Briefly, I just wanted to mention also on flexible spending arrangements. I don't know about you, but for me, I hear a lot of questions about this because of concerns with folks forfeiting dependent care and health FSA amounts due to no fault of their own because of the inability to use money they put aside for dependent care or health care during the COVID crisis, because everybody's life is different than what we thought it was going to look like last fall when we made our enrollment election. So we're working to try to get additional relief there. We got some relief during 2020, but we're working on efforts to let people carry over amounts they weren't able to use this year to next year so people don't forfeit their money they put aside, especially in the midst of an economic crisis. Briefly, I will mention a few executive actions that we've seen as well. As we all know, when legislative efforts fail, oftentimes we see the pendulum swing back to the executive branch to try to address the problem some other way. Eileen mentioned this earlier. You know, as soon as we say, okay, surprise billing efforts might fail legislatively, that means that we get an executive order saying that HHS is going to be proceeding on the regulatory side to try to address it. So this is a common ping pong back and forth. I wanted to briefly mention that on drug pricing, we did see some executive orders in July, which you may have read about in the news, including on drug rebates under Medicare Part D. There's a longish history here in which HHS had proposed to prohibit effectively drug rebates under Medicare Part D for PBMs and plan sponsors, but the administration actually didn't release the final rule as it was reported in the press because of concerns about increasing Medicare premiums. But the executive order released this summer said, please do go ahead, HHS, and complete that rulemaking, but first you have to make public a statement that says that it will not increase cost sharing or premiums under Medicare, and we haven't yet seen that. It'll be interesting to see if HHS is able to come up with a document that can support that position. And then we also saw what's called the Most Favored Nations rule, where the president is directing HHS to consider taking action to provide that for Medicare Part B and D. Medicare will say it will not pay more for certain drugs than other countries that have a similar GDP as the United States. That came out very recently. This is the executive order that the president said he was going to announce, but then decided to hold back for a month for negotiations with pharmaceutical companies, but then ultimately did release a few weeks ago. And as Eileen mentioned, we did also see a few weeks ago the American First Healthcare Plan executive order from the president, which primarily was symbolic, explained the actions the Trump administration has taken on healthcare, mentioned what Eileen talked about on surprise billing, indicating that if by the end of the year the legislative process is not able to result in a way to address surprise billing, that HHS is directed to do so, and talked about other items as well, including reaffirming the administration's commitment to support coverage for those with pre-existing conditions, which presumably was intended to address the criticism that they are seeking to repeal the Affordable Care Act, which includes the protections for individuals with pre-existing conditions. We could always see more executive actions. You never know, so we're watching for those. Lastly, before we turn to the potential next administration, as I mentioned, we have the Affordable Care Act in the Supreme Court. Yet again, the individual mandate under the ACA was reduced to $0 in 2019 under tax reform, and immediately there was a lawsuit because the basis for the individual mandate's constitutionality had been that it was a tax, and once it was reduced to zero, the argument was it's no longer constitutional, no longer really considered a tax, and so the argument was the ACA must fall. The district court agreed, the appeals court agreed that the individual mandate's not constitutional, but said, lower court, you need to do more work to figure out which parts and pieces of the Affordable Care Act have to fall with the individual mandate. What's interesting is it never actually went back to the lower court for that work. Instead, it's now been appealed to the Supreme Court, and an argument is set for November 10th, which I'm sure we've all read about. Something that's we're watching is what Supreme Court are we going to be dealing with at that time? Are we going to have 8 justices? Are we going to have 9 justices? We have to wait and see how that all plays out. There's so many different potential possibilities. And the Department of Justice, as I mentioned, has taken the position that the whole ACA has to fall. But as we also mentioned, the president recently issued an executive order saying that the administration thinks it's really important to protect people with pre-existing conditions. So lastly, I wanted to note that there was also legislation about a week ago in the Senate which was introduced, which would have prohibited the Department of Justice from taking the position that the ACA should be overturned. Although this did not become law, a number of Republican senators supported it, which goes to show the the kind of hot button nature of the pre-existing condition healthcare debate these days. And with that, I'm going to turn it back to Eileen to look ahead to next year.
Thanks, Katie. And certainly the outcome of that Supreme Court decision and whether the ACA stands or falls is going to be pivotal in looking ahead to what health policy is going to look like under 4 more years of a Trump administration or a new Biden administration. And even before the pandemic, healthcare was top of mind for voters. And the future of the healthcare system and employer-sponsored coverage was also front and center on the campaign trail for the Democratic nomination. In light of the pandemic and loss of health coverage resulting from the loss of a job for millions of workers, criticism of the employer-sponsored system has grown even louder. Former Vice President Biden, unlike many of his primary challengers, does not support Medicare for all and still envisions a role for employer-sponsored coverage. However, the shape of employer-sponsored coverage may nonetheless look very different under a Biden administration. In contrast to President Trump, who wants to repeal the Affordable Care Act and supports overturning the law in the case before the Supreme Court, Vice President Biden wants to strengthen and build upon the ACA, or rebuild it if, in fact, the Supreme Court strikes it down and he's elected. He would increase the number of people eligible for premium subsidies in the exchange and premium subsidies amounts, including those potentially with employer coverage. Specifically, the former vice president supports the creation of a so-called public option. That's a move opposed by President Trump. And under the Biden plan, all Americans would have the choice to purchase a new affordable public health insurance option like Medicare, whether they're covered through their employer buying insurance on their own or if they're uninsured. And as in Medicare, the public option would, according to the candidate's website, reduce costs for patients by negotiating lower prices from hospitals and other healthcare providers. Questions remain about the details of the plan and its impact on employers and employer-sponsored coverage. Notably, it remains unclear what, if any, changes would be made to the ACA employer mandate, again, assuming the ACA isn't struck down. And if Vice President Biden wins and Democrats control both houses of Congress, and particularly if the Senate changes the so-called filibuster rules or uses the reconciliation process, a public option in some form seems much more likely, and the answers to these important questions will be critical in shaping the future of employer-sponsored coverage as well. Now, I think even under President Trump, if he's reelected, the shape of employer-sponsored coverage could change significantly. In addition to the administration's current action to expand coverage not subject to the ACA, such as short-term limited duration plans, the administration could advance its efforts to create consumer-directed healthcare and the concept of a so-called healthcare backpack that employees could take with them and purchase in the individual market. But it's not just about coverage. The debate about healthcare is also about cost and making healthcare more affordable. And under either the Biden plan or another 4 years of the Trump administration, we can expect a focus on lowering healthcare costs. Biden's health plan calls for making healthcare more affordable and less complex for all. Little skinny on the details there, but the Biden plan has several proposals aimed at cutting the cost of healthcare and making it less complex to navigate. His plan calls for tackling market concentration across the healthcare system by aggressively using its existing antitrust authority to address the problem. The Biden plan also calls for addressing surprise billing by prohibiting healthcare providers from charging patients out-of-network rates when the patient doesn't have control over which provider the patient sees. But the plan, again, is short on details of how this will work. However, surprise billing fix, if it raises money for the federal government, may be a pay for broader healthcare proposals. President Trump has also called for addressing surprise billing, as we just talked about, and is also, the Trump administration, as Katie talked about, with respect to the transparency provisions, has also been very aggressive in issuing regulations promoting greater transparency. So I think a lot of changes ahead potentially for employer-sponsored coverage, regardless of who wins the next election. Katie?
Thanks. And I know we want to get to some questions, so I'll just spend a minute on drug prices and then briefly COVID response. So I think like Elise was saying, either way, we expect a lot of changes on probably coverage, costs, and I would say drug prices also will be a priority for whoever it is that's president and whoever their administration is, and we just might see the approaches be different. So based on the Biden campaign materials, of which there are quite a few, on drug prices, it appears that a Biden administration would support the federal government negotiating Medicare drug prices. And for certain drugs under Medicare, and the public option would impose inflation limits and would limit some launch prices and also would allow importation. President Trump has opposed government negotiation on drug prices for Medicare, but did sign into law a law banning the gag clauses for pharmacists, and also has taken actions to allow importation. That's part of the executive orders that I mentioned that had happened in July, and I think also some prior efforts as well, and has also proposed, but not yet fully implemented, a number of other things, as I talked about a few minutes ago, with regard to banning drug manufacturer rebates under Medicare Part D, and also this most favored nations idea. So the Trump administration has also taken a lot of steps to try to address drug prices, and it will be interesting to see how those continue in the coming years under whichever administration that we have. And then it would be remiss not to mention just the COVID-19 response for both administrations. I mean, as I guess makes sense, if there was no pandemic, I think Elise and I would be talking about what we think they were going to handle day one in terms of the other policy priorities, health policy priorities. For example, President Trump on his first day in office put out an executive order about reducing burden under the ACA. With this climate, it seems like the day one priority has to be COVID response. And so there are many plans available from the Biden campaign on what the COVID response would be, even separate from just the more general health policy platform. So President Biden would take on extensive federal government response to COVID, expand testing, provide no-cost COVID treatment, and expanded emergency paid leave, which per the website materials would be provided by the government, and also supports reopening the Affordable Care Act special enrollment periods for the uninsured in the individual market. President Trump, as we know, has signed a number of COVID legislation relief bills, and has also delegated a lot of the responsibility for addressing the pandemic to the states, and has opposed reopening the ACA enrollment. So I think by the day we get information on the different administrations, either current response or potential future response, and I would expect that to be the top item in particular for a new Biden administration. That would have to be something that would be day one plans, where some of these more general health policy items we've been talking about might be, I don't know, some other day than day one. And so with that, I think we can have Cheryl, if there's time, some questions.
Great, thank you for a great presentation. Clearly a lot going on, and I'm just going to note that we've gotten some questions in, and given the limited time available, what I'd like to do is work with Katie and Elise to respond to the questions offline and then send those out to everyone. But let me ask a couple quick, what I think are quick ones. So there's a lot going on in terms of regulations and requirements to disclose prices. Wondering if there is also a move to require quality measures to be publicly reported in addition to price transparency. Anyone talking about that?
Hey, Katie, you may want to talk about the comment letter that we just filed about reiterating the importance of quality metrics as the other piece of the value equation.
Right, yeah, like Elise was saying, yeah, so definitely, and I should have mentioned that earlier. As we all know, if we're talking about addressing healthcare costs, price transparency is useful, but you also need quality transparency. So both with the price transparency proposed rules that I mentioned included a request for information on quality transparency as well. So I don't think that we're going to get a final rule, you know, in response to a request for information, but the administration was trying to indicate that they know that's important. We had a webinar with agency officials after the price transparency rules came out, and I asked them, hey, what do you want to talk about? And they said, we just want to make sure that you emphasize that we understand quality transparency is important too. And then, like Elise just mentioned, in a recent annual Medicare rulemaking from HHS, they were doing updates to the Medicare quality reporting system, which is, I think, at this point, the most kind of broad-based hospital quality reporting system we have. And we submitted a number of comments there, both including that they do make changes and supplement that process to capture health equity issues, and also just expressing our support for efforts to increase quality transparency.
Thank you. We will handle the rest of the questions offline and get the responses out to all of you. I just want to wrap up briefly with a couple of comments. First of all, thanking Katie and Elise again for being with us today and providing this overview. I also want to note that if this is a topic, if these topics interest you, if you would like to have an influence, and work with other Alliance members to share comments with our elected officials about these topics, I'd encourage you to become part of our Alliance Health Policy Committee. We're in the process of recruiting new members right now. You don't need to be an expert, you just need to be a member of the Alliance and have an interest in these topics and be willing to lend your voice to the discussions. So with that, I'll wrap up, and thank you all again for tuning in today. Thank you, Katie and Elise, for sharing your knowledge with us and for our ongoing partnership. It's of great value to us. Please watch your inboxes for an evaluation, and you can let us know ways that we can improve this and future events. And thank you all, and have a good rest of your day.
Thank you.